It's my pleasure to start the second session by introducing Adrian Scott. Are you making your entrance yet? All right, there you go. Adrian wanted to make an entrance. You should have started from the back and walked all the way in.
Yeah,
that would have been
walk-up.
Yeah, and we would have had walk-up music. It would have been
That's
great.
right.
Adrian's going to talk to Adrian's at, of course, Johns Hopkins University School of Medicine at the Wilmer Eye Institute, and she's going to talk to us about the ultra-wide field imaging artifact facts. Thank you, Adrian.
Thank you, Sunil, and I'd like to thank the conference organizers for the opportunity to be here with you today. So we're going to talk a little bit about ultra-wide field imaging, how we've used it in some of our clinical practice and in our research, and then how I think what we need to be thinking about going forward. Here's my disclosures. There is material support from Optos in some of the work. So as we know, ultra-wide field imaging, we adopt this definition as when we're capturing 200 degrees of the retina or more. It's quick, it's non-mydriatic, and it's gaining increasing importance in screening, telemedicine, applications obviously from diabetic retinopathy, but everything from pathologic myopia, shown here, to a disease you think about as being primarily macular degeneration, also has some peripheral retinal implications in wide field imaging. Of course, the uveitis, choroidal tumors, et cetera, as we've heard. So there's multiple different platforms. These are just two of the most common. This is a Zeiss Claris and then an Optos. So artifacts, talk about artifacts. So artifacts are just things that make your image not able to get that whole 200 degrees of imaging. Let me go back one. Okay, so that could be your lid, your lashes, blinking, finger, cotton tip, somebody trying to hold the lashes up as we're taking the image. So these are things that make our ultra-wide field photos less than optimal. This is from a study by Carol Shields' group, and a child was referred after having an abnormality on ultra-wide field imaging here. Does anyone know does anybody have any guesses? Well,
did you get a green channel to do Prithvi's analysis?
I just found out about that today. I just found out about that today.
How thick is that?
How large? I mean, I think we need the green channel analysis.
I just found out about that today. That's a very good note. Okay. So does anybody know what this is? Or?
Pinky.
So it looks like
nose.
pinky.
I'm going to go with the nose.
It's a nose.
Go with the nose. Okay, so ultrasound was clean, right? Well, they published this, so I think it's.
Wait, they published this?
Yeah, this is and this is by Carol Shields' group. This is out for publication in Retinal Cases Brief Reports. But again, we're using ultra-wide field imaging so commonly for screening, and there was an abnormality there. And let's see, my pointer. Yeah, so.
Don't point at that. That won't help us.
Dr. Eller should correct. This is a nostril, right? So this is the person's nose, the little girl's nose. So there wasn't, a referral from.
Shut up. That was published?
This is reviewer one.
Yes.
This is reviewer one who rejected Yasha's paper.
Published, right?
Journal of, was this in the KJO?
Retinal cases and
we are
reports.
live on streaming, and there are people who like the KJO online.
All right. All right, so artifacts. So you have to be careful about what you're imaging because artifacts will come up. It's important to recognize these artifacts, minimize them. So obviously one way of doing this is a lid speculum. So a lid speculum, very uncomfortable for the patient, obviously, but can help minimize some of the lid and lash artifact. Okay, and let me see. So what we did is I tried to figure out, so the sickle cell retinopathy screening guidelines are somewhat amorphous. So we see a lot of patients who don't necessarily have actionable sickle retinopathy. So we put this Optos ultra-wide field primary camera in the hematology clinic. And this is a medical student and a study coordinator taking pictures. It's that quick, it's non-mydriatic. We had just brief training from the company itself, but they take decent pictures, okay? And what we did was we put the camera in and kind of imaged sequential patients with a known diagnosis of sickle cell disease. And the medical student and the coordinators and the team there were working with me to be able to take these pictures. And we publish this this is published too at AJO, and we published this to be able to say, can we pick up sickle cell retinopathy in a non-mydriatic setting in a hematology clinic by non-professional photographers? Can you give somebody limited training, and can they take a decent wide field photo where you can make a diagnosis of disease? And we had mass retinal specialist graders evaluate the images. Okay. All right, this is my, our best case. So this is a beautiful image. And you can see here, this is one of the patients, the one patient that we actually picked up unknown proliferative sickle retinopathy. You can see the CFAN lesion here in the periphery. And this patient got referred to retina clinic, underwent laser. Okay, so this is like the most beautiful image, and we got what we wanted in this case. We got a lot of things. So there are a lot of things. This is an image of non-proliferative sickle retinopathy. This is a black sunburst lesion. So you got a little bit more lashes there, but you kind of get, what you want to see in the disease. You're kind of getting the periphery, so you get the gist of what's going on, even though you're not capturing maybe the whole thing. Here, okay, so most of us can identify, obviously there's a good bit of lash artifact, but most of us can identify blood here, right? So this is old vitreous hemorrhage. This person looks like they have had laser before. This is an infarcted CFAN lesion. So we're happy there. We're getting what we want. The picture's not 100%, but we get what we want. But then there's a lot of images that came back like this, okay? So these are, again, my study team taking these pictures, and this is a picture that, for example, we would reject from the study because we don't really get to image or get to see most of the retinal periphery here. Who's to say there's not some horrible, lesion underneath the inferior retina that we're not capturing? This, for example, is not an acceptable image. It's dark, it's out of focus. There's something over here in the corner we don't know, too much lash artifact. And then we have this, right? So this is completely unacceptable. This is the person's entire eyelid, lash completely blinking over, obscuring the entire retina, okay? So how do we know and how do we tell, the person taking the image that, your image is not acceptable or this image is not necessarily capturing the degree of the retina that we need to? So the goal of our current work that we're working with the computer scientists at Johns Hopkins is to create an automated objective method to assess the quality of an ultra-wide field fundus photo to provide some sort of a metric to say, okay, this is artifact. And is this picture good or bad? And if so, is there a type of artifact that you can actually give feedback for? So yeah, working strongly with the team there in Hopkins in the computer science department, we created a neural network and trained them on a study subset of 1150 Optos ultra-wide field fundus photos. And the first thing we just said, okay, I went through with some of my retina faculty colleagues and just said, image, good or bad? Could you look at this image, not perfect, but can you say whether or not there's sickle cell retinopathy there or not? And then we split the data into training and validation and test sets. And you can see the ROC curve and the AUC of about 0.82, so decent, not perfect, but pretty decent. Okay. And then we took a second test set of images used to predict and assess the accuracy of each of the type of artifacts that you see here. So with the eyelash present, you can see the percentage of accuracy that we were able to say this is why the picture is not good. So eyelash present, about 87.8%, lower lid obstructing the image, upper eyelid obstructing the image is too dark, image is too bright, image just not centered. Okay. So with a very simple, at least for the computer science folks, algorithm, they're able to give us feedback and tell us whether or not, your picture is good enough or not, as to be able to diagnose disease, and if so, even what kind of artifact is there and what's present. So the goal of this research that we're still collecting fundus photos on and increasing the numbers of samples and refining the algorithm is to optimize this neural network to say whether or not the image is good versus poor. We can tell the photographer in real time, what's wrong with the image and why is this image not right? The goal of this is to try to implement teleophthalmology or try to refine some sort of quality control in a real world setting. These are used in primary care offices. There's, fundus photographs that are, in the drugstore, for the diabetics to take for screening. So we have to be able to get some sort of quality control. What are we taking? Are we taking the best type of photos? We want to give real-time feedback to minimally trained photographers as the type of artifact and the need for image reacquisition. And my goal with some of this is to refine sickle cell retinopathy screening protocols to have some sort of ability to put these sort of imaging capabilities in low resource settings and be able to we're not going to have trained photographers at our behest all the time. We need to be able to give the photographer some feedback, and that can minimize the patient needing to return and then refine our teleophthalmology screening protocols. Okay. I'd like to acknowledge my co-authors, including the Johns Hopkins Center for Engineering, Craig Jones, Matthias Unbrath, who are really the brain trust behind these neural networks, and the rest of my team, Johns Hopkins Hematology, and the patients. Thank you.
Thank you, Adrian. We'll do questions at Peter's panel. Next, my pleasure to welcome Dr. Richard Rosen. Rich is over at New York Eye and Ear, Mount Sinai, and had to make a long train ride. I think you took the L to the F, right? To get up here. Going to talk to us about management of retinal artery occlusions, leveraging early diagnosis using OCT with interventional stroke team thrombolysis to enhance outcomes. Thank you, Dr. Rosen.
Okay, well, thank you for inviting me. It's a pleasure to share some of this with you. Also, these are disclosures. Really, we had some foundation support, and these are acknowledgments of some of the many people that are involved with this. So this is a typical picture of acute vision loss in an artery occlusion, which you're all familiar with, and the typical cherry red spot. And the diagnosis is typically made late with IV fluorescein. But if you look at it with OCT, you can notice some very important features of inner thickening and hyperreflectivity. Of course, the thing that we always worry about is giant cell arteritis. And if you follow these patients over time, you see that gradually the inner retina just disappears. And so the natural history of this is pretty bad, right? And this was work Hayray published a number of years ago, so the bulk of the patients that he looked at, 122 got best of count fingers vision, and many worse than that. And then there was Schrag also said, well, there's about 17% spontaneous recovery, but that was like maybe to 2,100, not very good. So recently, the American Heart Association actually woke up to the fact that eyes are important also, besides just the heart. And so they published, and they said, well, this is really a medical emergency, and we should think about it a little more carefully, and there should be some way to prioritize early recognition. This was a paper that was done that also recognized about the same time that we needed a more accelerated way to diagnose this and to deal with it. Now, a lot of people have been thinking about this for a long time. This was a protocol that was done at Hopkins, and they used TPA to break up the embolysis or thrombolysis using small aliquots given every 5 minutes. And they had pretty good results, They basically 2 to 1 that, 75% of the patients improved as opposed to 33% who had the standard of care, and very few side effects. The big problem that we got into was there was a big multi-center trial that was done in Europe, the EAGLE trial, which didn't really show any improvement over standard of care. They used a higher dose of TPA, and they did patients out to 20 hours. And so standard of care turned out to be almost the same. And so there was a question about, there's many different centers, so each one only had experience with a few patients. And the length of time before most patients were treated was somewhere maybe 13 hours or something like that. Whereas actually the patients who got standard of care was a little bit shorter. And McGrory showed that in a small number of patients that they treated, that they actually got some improvement, but not that striking. This is actually a retrospective paper that was done from the stroke team. We did with the stroke team here at Mount Sinai, and we showed, they looked at 15 patients that they had treated, and about 2/3 of these patients actually showed significant improvement, but more than half had 3 lines, and there was a pretty good indication that this was much better than the natural history. Recovery went, some of them came back to 20/20, and most of them had better than 3 lines of improvement. So central artery occlusion has definitely been one of the areas that we haven't done well in ophthalmology. There's really been no standard of care. I mean, when I was a resident, we would have the patient breathe carbogen or blow into a paper bag, do a paracentesis, maybe try YAG thrombolysis, embolysis. And none of this really worked very well. And of course, these patients are all at risk for strokes, and they sometimes would get a stroke workup immediately, and sometimes it would take weeks. TPA has actually been around since 1984, using it for thrombolysis, and using small doses. You can see it works very rapidly, and it's very effective. And it's really turned around the stroke landscape overall in terms of larger strokes. They're more easily recognized, so patients tend to show up when they're like this, or they can't talk or something. Very often they come in a day or two later after they've lost vision. They didn't necessarily realize it. This is actually in our suite, where basically you can see that they go up through the groin into the ophthalmic artery, just the edge of the artery, and squirt a little bit of TPA until they see what they refer to as the choroidal flush, and that's an indication that they've got a good response. Here's an example of a patient who was 39 and vision dropped to 2400, and you can see that there's some whitening there in the papillomacular bundle. So it's a small branch artery occlusion, but it's fairly focal. And what you can notice is there's some focal loss of definition in the retinal layers. And so previous to treatment, there's sort of this patchiness to the choroid. And this is the patient's Amsler grid. So before treatment, patient's 2400, and they've got this large scotoma centrally. And after treatment, the patient actually came back to 2020. And the size of the scotoma got much smaller. Here's another patient who actually presented with count fingers vision in 3.5 hours. And you can see the patient had a fluorescein before they showed up. And there's really no flow within the arteries, but there's a little bit of collateral flow that makes it into the venous branches. And you can see here that there's sort of a diffuse loss of definition of layers. And after treatment, the patient came back to 2030. And the next day, the patient actually was back to 2300 because the protocol that they were using, unlike what they would typically do if they did a thrombolysis in the cardiac disease, they hadn't put the patient on Plavix and aspirin, so that was immediately added by the neurologist, and the patient the next day came back to 2030 and has remained that way for the next 2 months. Here's a young woman who woke up and noted painless loss of central vision in her left eye, and she described this sort of blurry area in her central vision. She had a history of sickle cell, and she lost the other eye completely from a similar type of event, and this was the scotoma that she drew out on the Amsler grid. And you can see she had a fluorescein which showed some central whitening. You don't really see very much going on. You can see the whitening actually on the color picture, but you don't see much going on in the fluorescein, although you can tell peripherally she's got a lot of dropout. No neovascularization, but so when you saw the OCT, you can appreciate that there are multiple inner layers, and you could refer to this as PAM, but it's probably worse than most of the PAM lesions that we typically see. Patient was immediately treated, and post-treatment, you don't see much change, but over a course of in a week, she was 20/60, comes back to 20/25, and ultimately 20/20. The biggest problem in this is that because the recognition, public awareness by the ophthalmologist is not very, in terms of the availability of treatment, is not very good. So this is what we're facing, and the key is rapid throughput. So a few years ago, I put one of these robotic OCT systems in our urgent care so that the residents and fellows would have an opportunity to do OCT in the middle of the night or whenever the patient showed up, and they really didn't need the skills. And I think that Adrian brought up the fact that if you have people who are not trained imagers, it's difficult for them to appreciate the artifact. But this particular device is fairly simple to use. It's like really point and shoot type thing. And you can appreciate the loss of the layers. This is the device, talks to the patient in 12 different languages, and so that they could get a picture. And so what we did was we decided that we would add this to our existing stroke network and put it in a number of the locations throughout the system. Here you can see typical ischemia pictures. Sometimes you only see sort of a rattiness to the layers. You don't see a complete wipeout. So the protocol that we set up now is basically if the patient comes in within the 12-hour period of time, they immediately they'll get a head CT, but they'll also get an OCT, and the pictures are then spammed out to a group on a protected network that so that all the retina people that are around can review the images and decide, is this an area of artery occlusion? And we have a number of emergency rooms throughout the area. And so in the last not quite a year, we've seen about 16 patients, of which we've treated 5 of them, and we've had some pretty good results. So I think that this is an area where we still don't have a fully documented, proven treatment, but thrombolysis seems to work pretty well. And the issue really is, how do you make the diagnosis quickly? Getting a fluorescein is not really possible most of the time. By the time you get the fluorescein, it's too late to treat. So being able to recognize this on OCT gives you the ability to make the diagnosis within a couple of minutes and get the patient on the table. So remember, time is retina. Okay, thank you.
Thank you. Next is going to be Rick Spade. Rick's going to talk to us about a new method of imaging the vitreous with boosted OCT. Thank you, Dr. Spade.
Thank you. I always like talking at Cole Institute kind of meetings. These guys are very smart, also very likable.
More likable or smart?
Completely
Which
different
one?
topic. I only have one talk.
Kissing ass will get you involved back.
How do you think Yasha got here?
Yeah, how could that happen? These are my co-authors. So the vitreous is involved in a lot of different eye diseases. We know about tractional things and macular holes and proliferative retinopathies, but it's also simultaneously a kind of mysterious structure because you really can't see it. It's optically clear. It's designed to be transparent. So therefore, it's difficult to image, and a lot of theories of the anatomy of the vitreous have differed greatly. ASRS was a guy who looked at the vitreous in the 70s and the 80s, and he made a drawing or idea of the vitreous like this, where he thought there were different tracks in the vitreous. He didn't even think there was cocase canal. You notice there's no bursa in his kind of representation. So what he did is he dissected autopsy eyes, and he just peeled off the layers. He said he peeled it off like parts of an orange. And then anything that was stuck to the vitreous that was left, he cleaned off with sandpaper and an electric toothbrush. That sounds like a good way to look at the vitreous, right? Mm-hmm. So first, he thought there were lots of cisterns and bursa. In fact, he thought there was 120 of them altogether. So what he did, we know some of them as like premacular bursa and area tomarchigiani to this day. And this was also during the 70s. So he dissected autopsy eyes, and he peeled off the outer layers. And then when he came to the peeling off stuff that stuck to the vitreous, he just let the eye sit in water until, what he said, it became putrid. Nice. Then he peeled off the vitreous, these layers off the vitreous, and he said it didn't bother the vitreous at all. That's kind of hard argument to make, I think. So vitreous dissection is hard to do, and there's a lot of questions about the validity. And I told you about the putrid and the electric toothbrush ideas. So they're done on autopsy eyes, and it's kind of hard to figure out, like you're looking at a patient at a clinic, what their vitreous really looks like when you think about autopsy eyes. Except here in New York, we have ways. So it's no easy way to study specific diseases. So an ideal modality to image the vitreous was something they can use on living people as high resolution, image the whole vitreous. Unfortunately, there's no ideal method right now. But we can use OCT, and when we get OCT image of the eye, it looks something like this. And we can make it brighter to see the structure of the vitreous, but then we lose the retina and the choroid, you can't really see it that well, and very few details are visible, mostly because there's too much noise. So with an ordinary OCT, the problem is that the images from the vitreous have very low signal-to-noise ratio. And often in ophthalmology, when we want to improve the signal-noise ratio, we average images together. But because the images are so poor, they're actually very hard to register. And so it's tough to average images with OCT. So what we did is just take 4 A scans at each location and average them before the Fourier transform, and that made a pretty robust signal. And as you know, B scans are made out of lots of A scans. And then, so they had enough detail that we could average them, so we can just use regular averaging technique with a Heidelberg spectralis. Now, the scanner that I use had 85 kilohertz A scan rate, so really effectively it is pretty slow, 21 kilohertz. And then we use eye tracking, just like an ordinary, and defocused up into the vitreous, average a bunch of scans together. Then I derived this kind of way of image processing that's kind of based on HDR photography and did volume rendering. So this is a vitreous of a younger person, and you can see that there's the fovea, and there's the premacular bursa, and there's the area marchigiani. So this is a younger person again, and you can see this is a superior part of the premacular bursa, and we can rotate that around. The yellow arrow shows where there's condensations on the top part of the premacular bursa. And those condensations are very common around any kind of bursa that you can see inside the eye. You can take the vitreous off and flip it around and look at it from the backside. The yellow arrow again points to those condensations, and you can see the premacular bursa, area marchigiani, and those white little arrowheads are what I call vitreous indentations, or vascular indentations. So there's some easy principles about looking at the vitreous. With aging, areas of liquid vitreous appear, and they're just pretty much hyporeflective. And next to them are areas where the vitreous gel starts to condense and they become hyperreflective. And so this is a patient, say, with early vitreous degeneration. This would be a person typically like in their late 20s. And you can see there's these sorts of lines that are present there. But they're really actually just ridges. We're having a hard time waiting for the next slide, apparently. You can see they're ridges, and in between those ridges, the vitreous is starting to liquefy. There's a little movie of that. Here's another person with early vitreous degeneration, also probably in early 30s or so. And you can see the premacular bursa, and you can see those sort of ridges that are present there. And we can rotate this, and you can see that there's areas of liquefied vitreous between those ridges. And we can see, again, how this is. And you can see the condensations of vitreous on the gel, and the liquid vitreous is next to that. And here's a movie.
Oh, that's great. That's a symptomatic floater, no doubt about it, right?
This is actually just somebody
So
about in their
where do you
mid-30s.
apply the laser?
Yeah. Right, yeah. I do 1,000 yags. So here's a person now in their 50s, and you can see the vitreous is generated. It looks kind of like cobwebs in a haunted house. This is through the fovea. And then here's a kind of a movie of that. But notice the vitreous really is still pretty intact. There's an idea that the vitreous degenerates and then it detaches because it's degenerating. And I'll show you the next part about PVDs. It's not necessarily true. So here's an early posterior vitreous detachment. You can see there's a kind of a clear space there that you can see the retina underneath the vitreous. And the vitreous, even though it looks like it's detached over a longer area, that's the cortical vitreous. I didn't really have enough time to talk about cortical vitreous, but that's the cortical vitreous that's still attached. And you can see it detaches here. There's different ways that it detaches, and the remnants that are left, they're described in a paper that should be out either now or soon. And here's a little movie of that. You can see underneath the vitreous into the retinal area. So here's a person with a more advanced posterior vitreous detachment. You can see the posterior vitreous face is lifting up, and you can see there's a round hole that's torn in the posterior vitreous face. And the very common thing that happens with posterior vitreous detachment, and the remnant of that vitreous is still attached to the retina. And a knuckle of vitreous comes through that. The premacular bursa is hard to see because some of the fluid that's in the premacular bursa disgorges through that round hole and goes posterior. This looks, it's kind of a round hole. There's still parts of the vitreous that are still somewhat attached in this case. And I peeled back a little bit. You can kind of get the idea that that's still tearing away from that. But it's a little bit easier in a pseudo-color picture to see that that tearing back. Here's a person now who has a detachment over the macula that's still attached to the optic nerve and elsewhere, but you can see how nice and round that hole is. The remnant of vitreous that's still left on the macula usually forms the basis of where the epiretinal membranes grow. And here, looking at the posterior vitreous face kind of like on edge, then you can see there's a knuckle of vitreous coming through that hole. And here's a little movie of that. So here's a little bit more prominent degeneration with detachment. You can see how big that hole is in the posterior vitreous face and the elevation of the vitreous. So some of the observations we can explain. I don't have much time to talk due to my host.
How much more time would you like?
Because it's you.
Because you're about to be cut off right now, so you know.
I'm just fooling. So, you know, collagen fibers that are in the vitreous, most of it's type 2, but there's also type 9. Type 9 doesn't spontaneously aggregate, but it has these kind of side chains that help it bind to glycosaminoglycans. It commonly coats vitreous collagen fibrils, so it's on the outside of that. Type 2 will spontaneously aggregate. So type 9 prevents type 2 from aggregating. Then in between, there's the high molecular weight hyalurons that we know about, glycosaminoglycans. The kind of curious thing is that with age, there's an exponential loss of type 9 collagen, and that allows the collagen to condense on itself. And there's also a dissociation of the hyaluron from the collagen fibers because the type 9 leaves. So they're almost like engineered to have this happen. So in areas where liquid vitreous forms, that's called synchysis. This dense vitreous is called syneresis. So there's a lot to talk about. I just want to talk about one thing is why do we have a premacular bursa? It's kind of unusual thing. You can see that in babies all the way up through adulthood. Everybody has it. So you can say, well, that's some kind of degeneration of the vitreous, but why would everybody have it? And why do we have things, generally speaking, that aren't evolutionarily important? So if you think about it, your eye moves, right? And the vitreous has a potential to put traction on the central macular region. Now, your eye moves 100,000 times a day. So you can imagine every time you move your eye, just because of this sort of inertial lag, vitreous traction we put on the fovea if the vitreous were really attached to the central fovea. But if you have a pocket of fluid there, no traction gets put on there. The vitreous then puts traction elsewhere around the central macula. Now, when you start to have a posterior vitreous detachment and it comes up through the macula, yeah, at that point later in life, which is a time when most people, humans, have never lived to, then you can get traction on the central macula. So just think about it. By the time you're 55, you move your eye about 2 billion times. You can't open and close a car door 2 billion times without something happening, but our eyes work great, right? So it's a pretty amazing structure when you think about it. Here's a 6-year-old with 2.2 billion eye movements. Still, everything looks pretty good. So there's a number of different patterns of vitreous degeneration. I really can't get into a lot now, but I think it has to be related to what's going on around the premacular bursa, the orientation of vitreous fibers in the outer vitreous, and just basically what time does with billions of eye movements. So the collapse of a degenerated vitreous is thought to lead to a posterior vitreous detachment, but I didn't really see that to be the case. As shown here, this is a degenerated vitreous, no PVD. On the other hand, here's a PVD in somebody who has fairly good vitreous. So in summary, I showed you some of the older ideas of the vitreous, develop a new method to create OCT images. This is in front of the FDA now. It's going to be part of the new Heidelberg software. Not so much the volume rendering, because once again, they said, well, how many more instruments are we going to sell if we put this software into it? It's none. But they're still going to have the basic idea of how you could do the software. And you can use it to examine disease states. Now, the one problem is that any volume rendering is killed by noise. Even if you reduce the arc to 23, you can see it's very noisy. So what we did then is to use AI to denoise the image, and you can see that even with arc 23 or 15, you get a pretty good image. And finally, I used AI also to segment the vitreous. And so the formed vitreous is kind of whitish. Clear vitreous is that sort of water aqua color. And we're going to just fly through the vitreous.
So I just need this for all those patients who come in complaining of floaters. So I just go, this is the problem,
Yeah.
right here. And then they get it.
So thanks.
Thanks, Rick. Thanks, Rick. That was the last talk you'll ever give at the Call Institute. I'm going to ask Rich Rose to come back because he's welcome anytime for retinal metabolic assessment using mitochondrial oxidative stress imaging, a new clinical tool for detecting and monitoring structural disease.
Okay, well, thank you again. So what I want to share with you is something that's still in development. So it's, but I think it definitely has potential. And I know that we've been working on this for a few years, and I think they're also doing it at Cole. You guys have seem to be actively involved in this area. Disclosures. So adaptive optics has really given us the ability to hone in on single cells, and this is not the limit. I mean, this is just like one more step, and we want to get into the subcellular details. So these are actually axonal varicosities that Alf Dubrow showed, which we believe, based on some histology images, that these are actually clumps of mitochondria. Of course, mitochondria responsible for electron transport and really producing the ATP that drives the cells. But they're subject to oxidative stress from a lot of different factors: hyperglycemia, aging, environment, and these things can lead to various forms of dysfunction, such as diabetic retinopathy, and we believe probably in macular degeneration, glaucoma as well. And this is actually image that from Dr. Chin and Dr. Singh's work at Cole, and showing how the stress of the ROS and various other factors lead to apoptosis with the cells due to the death of the mitochondria. So mitochondrial oxidative stress is really a key factor in many retinal degenerative diseases, and looking at flavoprotein fluorescence, which is what we'll talk about, is a clinically accessible tool now, and it may be useful for monitoring pre-structural changes that occur due to therapy. So in oxidative stress, you get oxidation of these flavoproteins, which increases the native fluorescence. And there are actually many of these. So the mitochondria are actually throughout the, here you can see they're stained sort of orange in the optic nerve and in the macula. And there are actually 18 flavoproteins that potentially can oxidize within the electron transport chain. And so this produces a fair amount of signal. And as flavoprotein increases, it goes along with increase in apoptosis and also the decrease in the mitochondrial membrane potential, which is key for maintaining the health of the mitochondria. Sorry. This is the device, which you may recognize. It's basically uses a light source at 467, short blue wavelength, and then looks at the fluorescence at 535. Now, it then gives you an average flavoprotein fluorescence of the area that you're looking at, and a reading of the variation, or what they call the heterogeneity. Here's a typical output from this device. Now, here you can see the difference in the typical autofluorescence. Now, the advantage of this is that this is an active autofluorescence that we can actually see changes with, as opposed to lipofuscin autofluorescence, which you can see the yellow on the right. It's a longer, it tends to be longer wavelength, but lipofuscin autofluorescence doesn't really change. We look at it and see this is what happened, so it's almost like archaeology. But this is actually potentially variable. And here you can see the difference looking at the same eye with two different spectra. So when you look at the flavoprotein fluorescence, you can see that it's very different than what you look with the lipofuscin spectrum. And here you can see an example of a control eye versus a patient with diabetes who has a higher signal, and then diabetic macular edema, which is even higher. And it has pretty good repeatability in terms of, this is actually a third-generation device that we're using. Now, there have been a number of papers over the years that have been published. The work was originally started at the University of Michigan, and they were interested in diabetes primarily. They showed that in diabetics you saw increased levels in patients who have active central serous, age-related macular degeneration, and optic nerve disease as well. And with age, you get increase of this fluorescence, as well as with diabetic eye disease. And here you can see even with the difference between retinopathy, which is a little more peripheral, versus macular edema, so you get higher levels. We also looked at glaucoma, and you can see as the glaucoma progresses that we saw higher levels of autofluorescence. So one of the interesting applications of this is you can actually monitor therapy. And this was one example that was done early on, where they looked at a patient who was treated with triamcinolone who had macular edema. And you can see that after the triamcinolone, there's a reduction in the flavoprotein fluorescence. But when you add an anti-VEGF, it actually suppresses it even more. And here you see the response on this histogram. We looked at a group of patients who were undergoing treatment with anti-VEGF and looked at the correlation and the response, and you can see that after treatment, we actually saw an earlier response from the flavoprotein fluorescence, which you would expect than what you see in terms of the edema. And this actually correlated closer to the visual function than what we got with the macular edema. This is some work that was been done at Stanford where they were interested in optic nerve disease, and they looked at various scenarios where you had stressed optic nerves, and you can see that after the stress is removed, in this case it was a decompression from a CC fistula, that there's a reduction in flavoprotein fluorescence. Here's one where decompression after lymphoma, again, reduction. Here's one from an interconal mass, reduction. Here, interestingly enough, you can see that when these patients, here's a couple of examples of patients with non-ischemic, non-arteritic ischemic optic neuropathy, and you can see there's a big increase. So you compare the two eyes of this patient and the difference in the amount of fluorescence. And here's another example where you see a similar kind of disparity. Here's actually, interestingly enough, when you have optic nerve drusen, which probably contain calcified mitochondria or some sort of damaged mitochondria, you get very, very high levels that are almost off the chart. So these appear very different in terms of these are particularly high. The glaucoma group actually did a small study where they looked at using this as an adjunct therapy. And so they put a group of patients who, on a series of neuroprotective agents, nutritional agents, and found that they significantly reduced the levels of flavoprotein fluorescence in the macula of these patients compared to the placebo. So recently, in my lab, they've been looking at a variety of different diseases, and you can see that there's definitely a difference between the non-ischemic forms of disease, such as ischemic versus non-ischemic branch vein occlusion, in terms of levels of flavoprotein fluorescence. Here's an example of active versus inactive central serous, and you can see the difference. And here's a patient with diabetic macular edema, and when you have active edema, you have much higher levels of fluorescence. And then here's one patient with active exudative AMD. The intensity seems to correlate inversely with best corrected visual acuity, and basically patients who have various forms of retinal disorders or optic nerve disorders are significantly higher than controls. But they're still in the process of trying to develop normative databases. So actually measuring pre and post treatment seems to be a better application for this. There's still issues with this technology, and that has to do with creating accurate offsets to compensate for the difference in fluorescence between the native lens or an IOL. So we're still working on trying to do that. But you can see that, again, there's a much bigger difference between patients with disease and healthy controls. So I think that this is a very promising area to measure and may be useful for looking at the impact of therapy and looking at substructural changes. And so to be continued, there are ongoing trials. Thank you.
Excellent. So, Peter, you want to do questions during your panel?
Yeah, sure.
All right.
Let's take some questions. Anything from the online there, Justice?
Hey, Rick, your analysis, was this just using, just a standard Heidelberg OCT, and was it your own specific software analysis, or how'd you do it?
Yes, it's my. We changed this. The Heidelberg software was changed through the 4A scans before the Fourier transform. That's going to be the part that's coming out. It's a slower scan. That gives the greater detail. But the whole idea of then how to process it, I developed that. Yeah.
So, Adrian, on your quality assessment, we've looked. It's such a big factor in the Optos images, and it's interesting when we've looked at it in the quantitative angiography side. Although when you look at it subjectively, you get all this information. When you actually try to quantify it, you end up smaller and smaller and smaller. And we've looked at that from an automated quality tool as well. Have you used, it sounded like you literally just gave the images with a binary grade. Are you also considering doing any sort of labeling or annotation around features to look for enhancing the quality performance on that for the fundus photos?
Yeah, the second part of the experiment was actually trying to label the image, teaching the algorithm what is an eyelash, what is too dark, what is too bright, what is off-center. So the second part of the algorithm was trying to be more specific about what the artifact was.
Yeah.
So we're trying to give the photographer, tell you not only is your picture not good enough, but, some sort of theory as to why, as far as specifically the artifact.
Yeah, and that real-time feedback would be so huge, for us to have, where the photographer could literally, it just pops up and says not good enough, and then if you add the Y as well, was it easy to have this standardized, what is too bright? It's hard around that. We found in doing that. How did you guys go about doing the kind of scale around that?
Yeah, and it's subjective too, and a lot of our graders, so for example, Dr. Goldberg, Mort Goldberg is one of the graders with me, and he has very low tolerance for wide field imaging. It's like he hates it, it's all horrible, the pseudo color, and he has a very high rate of throwing out images because of
It must be an old chair
cheering,
thing.
Dan is cheering for that. And other colleagues, so Dr. Alvin Liu and I were some of the other, graders, and we have a little bit more tolerance for that, so it's subjective, right?
Yeah.
So, I try to figure out what's the best way. It's all about what I think is good and bad and able to be graded reasonably.
Well, I mean, several of us run reading centers, and that's really the biggest issue is garbage in, garbage out. If we get a scan we can't use, we miss that data point. So being able at the site when the patient's still there to have some sort of QA done quickly to let us know, either in your case wide field is incorrect. In my case, is the OCT good enough? You can use some of the values, but ideally, at the bedside or at the imaging device to have that would be amazing.
Yeah, and some just we were laughing about the referral for the child's nose, but some providers use these wide field images as their ground truth, and they do them on patients, and you have to know what you're looking at. You have to know and understand what's a good picture and what's not, and that's one of the reasons why we're kind of doing this work, because you want to be able to, anybody can take a picture, but if you don't know what you're looking at, as you said, garbage in, garbage out. And some of them, some offices kind of use these as their standard of care, unfortunately, for screening.
So, Richard, some of these mitochondrial imaging, I mean, it's fascinating, especially in dry AMD, for instance. There are several companies looking at this idea of reducing oxidative stress, whether it be through microcurrent stimulation, light stimulation, stealth with elimipeptide, Allegro with rizotiginib. How reproducible is this? Is it ready for prime time? Is it ready for a clinical study? Would Wiley accept any of these outcomes?
So the original device that we worked with was an erector set version. It was really Frankenstein. But currently it's in the EDON camera, which is a pretty reliable vehicle. And there's good repeatability within an individual patient. The hard part in fluorescence is looking at large populations. So that's still what they're struggling with in terms of normalizing it across lenses particularly, because that adds a lot of artifact to the image.
Can I ask you, how do you differentiate this from regular lipofusin?
It's done with a notch filter. It's really at the short end of the curve, so it's before the lipofusin curve.
Because
It's
Heidelberg
a very narrow notch filter.
uses a 488 excitation and 500 for the fluorescence. And that's kind of where you were at. So if they're calling it lipofusin,
Well, they probably have more than lipofusin.
yeah, but you're probably having more than flavoproteins.
No, it's a fairly narrow.
Well, I just told you the way.
Don't you
the same.
love it when geniuses like argue with each other in front of you? You just sit back and just go, wow. All right. Any questions from the audience on the last panels, which were spectacular? All right. So this last section is really meant to be sort of like image potpourri. It's image recognition. I'll let the panelists be able to just shout it out. So if you think you know what it is, shout it out. We're going to try to go through this really quickly. These are not hard cases, but very relatively.
You're not showing us any OCTA images, right? Because
I may.
I could say
I may.
I could say anything that would be right.
Yes.
Peter Kaiser disclosure.
Yes.
Got it.
None of them are relevant. I might
Is that
point
like
out.
a phone book? Or
Wait, hold on. There's page 2. Wait, get
Page
to
1
page
of
2.
7.
And this was approved by Dan Martin. 15-year-old male, decrease in vision, ADHD. The mom thinks he's BSing, that he has this decrease
Laser.
in vision.
Nose.
Laser. Laser. Amen.
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 Very quick, very easy. And here you get to see over time the patient's getting better. But this is just one of those ones that once you see that pattern, and you just don't miss it. And we had a great talk on this today already.
And was he on medications for the ADHD?
He was.
Yep.
49-year-old woman, wavy, distorted vision, 20/30 vision.
How bad is her bladder?
Oh, wow, that was fast.
Yeah.
So yes, pentosan polysulfate. Everybody know about this entity? Yes, no, yes, good.
Are you
This
guys
is-
screening for this at the clinic, like in some intelligent way? Like, 'cause
We are. We
don't
have an
specifically, like,
EMR alert that fires every time it's ordered, and
that?
we have an EMR set up so that when it's ordered by anyone, it's found in an encounter with either OB or urology, they automatically generate a referral to ophthalmology.
Are they still ordering it a lot? Because I hear controversy that it doesn't really work. And people
Yeah.
are saying,
Yeah, there's less and less that's being ordered, but anyone who's actively on it automatically triggers an alert if they haven't been seen in the last year.
is there any alternative to this drug? Isn't this like the only drug that's out there?
It's the only drug.
It's the only- well, and it's
only
interesting.
thing.
I've only seen a handful of patients, but the couple that I've seen are very stressed about this, but they've also told me, interestingly, that they've been miserable until they got put on the drug. So at least anecdotally, in those few, it seemed to be working. And
I love the ads at night from the lawyers about this. It's
well, you got,
exciting.
Why are you
50%
staying up late
placebo
watching
effect.
TV? I think that's a better question.
All right. How about this?
Mechanism.
What medication are they on?
MEK inhibitor, exactly. Usually bilateral, oftentimes bilateral, CSR, VKH type of appearance. Dose dependent, so increased fluid depending on the dose. Here's the other eye. 54-year-old referred for anti-VEGF treatment, decreased vision in both eyes, decreased vision.
Best? Or like
Best.
the
So, yeah.
vitelliform?
Yeah, so the clinical exam would actually have been helpful in this case, making it very obvious.
The vertical OCT helps too.
But yeah, I mean, just this pattern, especially for the fellows out there, just kind of when you see that, you know, this is obvious. The fundus autofluorescence would be obvious in this case. But the number of times I've seen this be referred in and having received anti-VEGF is actually remarkably high. So 33-year-old male went to Mexico, had an illness like many of us have when we go to Mexico.
Oh, God. seriously.
Comes back.
I mean, the Koreans and Mexico, you're killing us.
Who made fun of the Koreans?
You did.
I
just
did
before.
not.
Yes, you did. Absolutely.
When?
And Rick Spade. You did like all
Oh.
three at once. Like one whole thing.
I love Koreans.
Didn't say anything about Rick Spade, though. That's interesting.
Here, OCT. Anything there? Nothing. Nothing. About a month later, here's the OCT. Have you guys seen this entity ever? Oh, I'm stumping some people here.
Did he have any rash on his hands or feet or anything?
No, but he had this viral thing.
Yeah, that's facts.
Was he really high fevers or not so high fevers?
Not so high fevers.
Got a pretty ratty EC line, huh?
That sort of bullseye-like pigmentary change. Yeah, exactly.
They didn't have a rash?
No rash.
Yeah.
Infant mouth.
So unilateral acute idiopathic maculopathy,
They
which,
usually have a rash on their hands.
Yeah.
yeah, this, he didn't have a rash.
Toxic.
No rash. Again, we have no idea what this
That has
is.
nothing to do with Mexico. That's being around
That was just a red herring.
That's the
Yeah.
cruise. It's the cruise.
It's being around
Maybe the
little
kid-
kids, so you'd expect Biden to have this.
Peter doesn't like little kids either, so it's fine.
I try to get uveitis and peds and tumors out of my clinic as fast as humanly possible. Next case.
Or too much
Actel.
of it.
Easy.
Oh, there's Pactel.
So, I mean, you can see it on OCTA. You can certainly see it on the OCT. Next case. The audience should chime in and beat the panel. Come on now. We already know what this is. If you listen to Richard's talk, you know what this is.
NF1.
Hammered. Oh,
Artery.
Yeah.
Interest combined.
Still hamartoma?
nope.
How about just a BRAO? Would that be okay?
The occlusion.
Yeah, so this is a BRAO secondary to COVID vaccine. So we're starting to see
It's a
some.
lot of hemorrhage for a BRAO.
Yeah, it's,
Yeah.
It's almost
Well,
like
it's more than a
or-
BRAO. It's
secondary.
BRAO plus?
I'm sorry?
that's illegal retinal artery.
It's maybe, you know,
The vein
but
occlusion was silly retinal
Yeah,
artery.
Yeah.
Yeah.
there's venous tortuosity.
it's more just the fact that this was after the COVID vaccine, and we're starting to see, obviously, many people have seen vascular changes after that. All right, that was easy. Patient referred in for lesions. Prithi, you should get this in 1, 2, 3.
A sclerocortical calcification.
Exactly. Usually along the insertions of the obliques, patients get sent in for this. Just memorize that look. Just for fun, we did an OCT, but the diagnosis is clinical.
Ultrasound.
Ultrasound.
Well, if you
That would be a
really-
referral, right, immediately from your clinic.
Green channel analysis. That's what.
So distorted vision, loss of vision. You got it already?
Yeah.
Wow, she's fast. Pitt. Justice should have got this in a millisecond because it's his patient. Didn't, but just showing you different aspects of an optic nerve pit. All right, ready? 73-year-old white male, decreased vision, floaters,
Beat up?
B-dump. So Everybody know what speed bump is? Yeah, we're good. So this is a cool case. This was seen at the clinic, and I just love the appearance. The clinic people, nobody should say anything.
Oxalose.
Oxalate.
Yeah.
Yeah, exactly.
But was it?
Oxalosis.
So oxalate, it is. But that's why I said, you know, I mean, you've seen it before. No fair. But extreme ischemia. Obviously, this patient was due to primary hyperoxaluria, required hepatic renal transplant. Treatment, I think you did what, PRP, Avastin, something like that?
Double layer.
Double layer sign. I think we have, let's do one more because we have 16 seconds left here. Presented from diabetes clinic, type 1 diabetes. Huh?
She already got it. Mids.
Nice. Now you have to show pictures. It's beautiful. It's perfect. So mid. All right. Well, you know, I hope this was fun for you, just going through some quick cases here. I'm going to let Sunil close up the meeting.
Well, what a great meeting. We learned a lot about Peter's disclosures. And I want to thank all of our sponsors first for, I'm not jealous. Thank all of our sponsors for their support. Thank all the audience for being here, everyone online. Our fantastic speakers, what a great job. Let's give them a round of applause. All right, and the Vista team who's up here ready for us to do the lottery draw for, how many do we have, 2?
I think we have 2.
All right, 2. All right. Do you want to pick?
Only one here.
All right. You're going to pick one? All right. You have to be here. Dan Martin.
Yay,
No,
Dan.
I don't know how that happened. I don't know how that happened.
He has no idea how to do this.
No, sorry. It's Rachel Downs. Rachel. Well, you can give it to Dan Martin. You can come up and get it. Somebody take a picture of this and put it on social media so that, and there you go.
They can win a second one.
That's right. All right, here we go. The second one. This is the nicer one? All right, this is the nicer one. Sorry, Rachel. I'm sorry, here we go. All right. You ready?
Ready. Bated breath.
I think you won last time. I think Hassan won again. Hassan, are you here?
All right.
Hassan, did you win? No, it's Hassan, not you. You're in, Hassan Seaton. Yeah, you won. Yes, Hassan, you won. There you go. Congratulations. You're welcome. That's all right. I might have a third one. We can give one out to you as well. That's fine. Peter, any last words? It's a used one. Peter, any last words?
No, I mean, you know, we really enjoy doing these summits, and I guess it's been 10 years of doing it. You know, it's from an educational standpoint, we love doing this, and please come back year after year. We, as I said, do a retina summit in front of ARVO and the imaging summit in front of ASRS. So thanks for coming tonight, and for those of you watching online, thank you for. I can't end it. Dan has to end it.
No. You can end it. I just wanted to say that even if you can't join us in person, join us online. Jar, how many? We had 350 people. So the majority of the folks who are not in this room. So, but a lot of people have been listening online. So, hope that if you can't join us in person for the next one, please join us online.
Great. Thank you all. Have a good ASRS.